Well, it's a pleasure to be speaking to you all today, and I'll be talking about the diagnosis and management of metabolic dysfunction associated steatotic liver disease, or MASLD, which was formerly known as non-alcoholic fatty liver disease. These are my disclosures. So I'm going to touch upon the new nomenclature just to give some understanding of why it happened and how it relates to our old NAFLD nomenclature. Touch on the 2023 American Association for the Study of Liver Disease guidelines, and which really gives some practical advice for the management. Talk about diagnostics and then treatments. So the new nomenclature for non-alcoholic fatty liver disease was decided to be changed several years ago, and this is for several reasons. The first is because a NAFLD diagnosis was steatosis more than 5% of hepatocytes in the absence of significant alcohol use and in the absence of prior liver diseases. So this wasn't characterized by positive criteria. It was a diagnosis of exclusion that made it hard for people clinically and in research to diagnose this condition. The use of fatty liver was considered to be potentially stigmatizing language. We had patient input that suggested that. And so there was a desire for a standalone disease name and criteria that didn't rely on exclusionary criteria. So the renamed metabolic dysfunction associated steatotic, meaning fat, liver disease, or MASLD, is diagnosed by steatosis either on imaging, biomarkers, or on liver biopsy with at least one of the following metabolic criteria. And you'll notice that these on your right are similar to the ATP3 criteria, except for instead of just waist circumference, it can be a BMI of greater than 25 or an elevated waist circumference, fasting glucose that's elevated, or the presence of an elevated A1C or treatment for type 2 diabetes, hypertension, hypertriglyceridemia, and low HDL or lipid lowering treatment. And these provide clear and a positive diagnostic criteria, and they can stand alone or with other distinct causes of liver disease. It's important to note that the diagnosis of MASLD does not exclude other causes for liver disease, and there is a need for workup. Statistically, MASLD is so common, up to 37% of adults have it, that it can travel with other liver diseases. And so for people with abnormal liver enzymes, it is recommended that they undergo a standard abnormal LFT evaluation. So steatotic liver disease is the new overarching term for fatty liver disease. And I like this because it encompasses not only MASLD, metabolic dysfunction associated liver disease, which we just talked about, and alcohol-related liver disease, but something called MET-ALD, so MASLD plus increased alcohol intake. And these are patients that have both metabolic disease and high-risk alcohol use, who probably have disease because of both contributions. This, I think, will make it certainly easier to study this condition and to identify treatments. So moving on to the practice guidance document that was published in 2023. This focuses on actionable statements rather than formal recommendations, and they are based on the highest evidence used, but expert opinion is used when high-level evidence isn't available. So what I really appreciate from this is, first of all, how do you stage for MASLD? And they talk about this here. When we have a patient who has metabolic dysfunction associated steatotic liver disease, they provide this algorithm for how it should be handled in the non-GI setting and within a GI setting. And I'll break this down a little bit. In the primary care or non-GI setting, the first goal is to identify patients who are unlikely to have advanced fibrosis. So those patients with advanced fibrosis, which would be stage 3 or stage 4, are at much lower risk of progression than those with stage 0, 1, or even 2. And so those people don't necessarily need to go on to advanced care. To determine this, it's recommended to use the fibrosis 4 score. So the score that uses age, AST, ALT, and platelets, and can be calculated simply with an online calculator. If the score is less than 1.3, then those patients don't need any further evaluation. They're at very low risk of having any advanced fibrosis. And it's recommended that they have a FIB-4 every 1 to 2 years if they have metabolic risk factors, and every 2 to 3 years if they don't. If patients have a very high FIB-4, greater than 2.67, they should immediately go on to referral because they're at very high risk. Now, what about this group in between? Well, these are people who should undergo a secondary risk assessment. So when the FIB-4 is elevated, they should either have an ELF score, so an enhanced liver fibrosis score, which is generally a send-out test, or a vibration-controlled transient elastography or FibroScan. And this guidance document gives levels for VCTE or FibroScan, but you can use ultrasound-guided elastography and use the scoring that you'd get on reports for those. Here we say that patients who have low VCTE, less than 8, or a low ELF, can again go on to periodic assessment with FIB-4, but don't need further management. But those patients who have intermediate or high VCTE or ELF scores should be referred to hepatology for additional assessment. So let's just touch on this ELF score, which is relatively recently FDA approved for use. It's a score that's a send-out test for most labs. We don't have it where I work at Mass General Hospital. It is a send-out test. And it's a set of extracellular matrix markers, including tissue inhibitor metalloproteinase 1, amino terminal propeptide of type 3 procollagen, and hyaluronic acid. So markers that are used in fibrosis development, fibrogenesis, or fibrinolysis. An 11 study meta-analysis showed that it has a very high sensitivity to detect F3 and F4, so stage 3 and stage 4 fibrosis. So for people who don't have access to a FibroScan or an ultrasound elastography, an ELF test can be done. What about when we see someone, what should happen within the GI world when we see somebody with these elevated tests? So what will happen? Well, this is when a liver biopsy can be considered. The goal is to identify at-risk NASH patients, either with a NASH activity score of 4 or higher, or fibrosis of 2 or higher, or advanced fibrosis. Patients can go on then to have a biopsy, or, and I would recommend this, consider additional stratification with MR elastography. And that's a lot of what we do in our practice. So we're getting away from biopsy, except when we think patients have diagnostic uncertainty, where they may also have autoimmune hepatitis because of very positive autoimmune markers and fatty liver, or a second condition. In that case, we go on to biopsy. But for patients who don't have that, we're generally referring them for MR elastography, which has very good performance characteristics. So a biopsy really should be thought about now only when you have indeterminate or conflicting non-invasive tests or advanced testing is unavailable. There's diagnostic uncertainty about the cause of liver disease. The guidance documents say we can consider it in persistently elevated aminotransferase levels. I would say that's really only in patients who've had a negative workup otherwise and who have AST and ALT out of the range of what's reasonable for MASLD, which would be greater than 300, or when it's required by insurance. And we'll talk a little bit about this. I know that at the Veterans Administration or VA hospitals, Resdifra or resmetirom, which we'll talk about, the approval requires a liver biopsy showing stage 2 or 3 fibrosis. So what about treating MASLD first? And we'll get to the exciting news about Resdifra at the end. Well, the first, and the guidance documents state this, really the first for patients who have overweight or obesity is to work on a diet leading to a calorie deficit, limiting carbohydrates and saturated fat, one that's high and enriched with high fiber and unsaturated fats. Usually the Mediterranean diet is what's recommended. That's been shown to be helpful in patients with MASLD, and patients with MASLD have an increased risk of cardiovascular disease, and so that's also helpful in those patients. This is a study that shows that weight loss really can help MASLD and fibrosis. And it was a study published by Vilar Gomez out of Cuba in gastroenterology in 2016, where patients underwent a liver biopsy at baseline and then at 52 weeks. In the interim, they were advised to undergo a low-fat hypocaloric diet, decreasing by 500 to 1,000 kilocalories per day, and advised to start moderate intensity walking 90 minutes per week, increasing to 200 minutes per week. They underwent individual visits with an RD and then group visits with an RD. But these patients weren't randomized. This was a cohort study. And so the intervention really was just educating patients about what they should do. Now, what happened was that not a lot of patients lost weight. Only about 30% of patients lost even a 5% total body weight loss, and 10% lost a 10% or more total body weight loss. That's the bad news about the trial, but the good news is because there was this range of weight loss, the investigators were able to look at the impact of different amounts of total body weight loss on liver biopsy. So you'll see here on the y-axis changes in liver biopsy, and here differences in the total body weight loss, less than 5%, 5 to 7, 7 to 10, and more than 10%. And I want to highlight two things for you. When overall, 25% of patients had resolution of their steatohepatitis. But when patients were able to lose at least 10% of their total body weight, 90% over the course of a year had resolution of their steatohepatitis, and even 64% when they lost 7 to 10%. So if you can achieve significant weight loss in patients, they really can improve both the fat and the inflammation in their liver. And more importantly, when you lose at least 10% of your total body weight, 45% of those had regression of fibrosis of at least one stage, and 55% had stability. So no one who lost 10% or more of their total body weight had progression of their liver disease. And that's distinct from those who didn't achieve significant weight loss, where 21% worsened over the course of this year. Even in this case of 7 to 10% total body weight loss, no one progressed, but we saw much less regression. So the recommendations are a hypocaloric diet with a goal of a 10% total body weight loss to improve NASH or a MASH, as we'll now say, in the majority of patients, and even improve or at least stabilize fibrosis. So what about exercise? The guidance document encourages increased activity to the level and extent that's possible. And individual prescriptive exercise recommendations have been shown to increase sustainability. Exercise does work, physical activity. There's a meta-analysis of 20 studies with over 1,000. These were NAFLD patients at the time. And exercise was shown to improve the ALT, the AST, and the intrahepatic triglycerides, so fat on MRI, regardless of weight loss. So I tell my patients, even if you don't lose weight, exercise is helping the liver, presumably decreasing inflammation with AST and ALT decreasing and decreasing liver fat. Exercise with diet has been shown to improve liver biopsy, decreasing the NAFLD activity score, which is a composite score of steatosis, hepatocyte ballooning, and lobular inflammation. And importantly, there's no difference in these studies between the benefits of aerobic exercise and resistance training. Now, the amount of physical activity that's recommended is quite high. Moderate intense activity of 150 to 300 minutes per week, or vigorous activity of 75 to 150 minutes per week. But one interesting thing that I think about is resistance training, which is also beneficial at 120 to 140 minutes per week. And it can either complement aerobic exercise or stand alone. We find in our practice that patients are more likely to start with resistance training when they haven't had any exercise history before, because it's less intense and there's less energy consumption. So it may be more feasible, especially as a starting point for those with limited cardiorespiratory fitness. We do use this prescription from Exercise is Medicine and from the American College of Sports Medicine, which has specific recommendations for people who have non-alcoholic fatty liver disease, or what we now call MASLD. So we do give this out, and this is where you can find the exercise as medicine guides, which are specialized or for a number of different conditions, including MASLD. And I love this quote. Even though we talk about that we need 150 to 250, 300 minutes per week of exercise, the European guidelines carefully and importantly point out that any engagement in physical activity or increase over previous levels is better than continuing inactivity. So I encourage my patients to do anything they can, even if they're not hitting these goals that have been shown to improve the histology, they're likely improving their overall health as well as some non-invasive components of MASLD. What about pharmacotherapy for weight loss? Well, several of these compounds have been studied for MASLD. We know that there are a number of FDA-approved medications, but liraglutide has been shown to improve MASLD and a trend toward an improvement in fibrosis. Semaglutide has been studied and was published in the New England Journal in 2022, which showed an improvement in NASH histology, although not a change in fibrosis. And there's early data for tirzepatide showing non-invasive improvements in fatty liver or steatotic liver disease. What about endoscopic, bariatric, and metabolic surgery? Well, the guidance say they are promising, but additional data is needed. As you all know, there are a number of FDA-approved devices and procedures, several of which have been studied in NAFLD and seem to certainly have a benefit in non-invasive tests. We don't recommend this for treatment for MASLD alone, but for patients who have other indications for these therapies and who can afford them or who are covered, we certainly recommend that they be evaluated for them. And bariatric surgery has definitely been shown to be beneficial. Moving back to endoscopic bariatric surgery, there is a meta-analysis of endoscopic bariatric and metabolic therapies of 18 studies, over 100 patients, where the average weight loss was about 4.5% of the total body weight loss over 6 months. And they saw a decrease in liver fibrosis, not by an entire stage, but by 0.7%, and this was only over 6 months' time. And they saw significant improvements in the ALT, the steatosis, and the NAFLD activity score on biopsy. So there certainly is data that there is benefit, although the fibrosis data isn't as strong as we would like to see yet. So what about bariatric surgery and NAFLD? And I highlight this really important study that was published in JAMA in 2020. There was a Splendor trial that looked at surgical procedures and the long-term effectiveness in what was called NASH at the time in patients with obesity. And they examined two things. They took a group of patients who had had bariatric surgery and compared those propensity-matched patients who underwent usual care without surgery. And they looked at the development of two things: major adverse liver-related outcomes, or MALO, which is a composite endpoint of progression to histologic cirrhosis, the development of decompensated disease, the development of hepatocellular carcinoma, liver transplant or liver-related mortality, and also the development of major adverse cardiovascular events, or MACE, another composite endpoint of coronary artery events, cerebrovascular events, heart failure, or CVD-related mortality. They looked at over 1,100 patients who had both NASH and obesity, primarily at the time who underwent Roux-en-Y gastric bypass, although 17% underwent sleeve gastrectomy, and compared them to a non-surgical group who had received usual care. What they found, and we can see here on the left, is major adverse liver outcomes, that those patients who had bariatric surgery had significantly fewer major adverse liver outcomes than the non-surgical group. And this was also true of the major adverse cardiovascular events. So patients with NASH did much better from a liver standpoint and from a cardiovascular standpoint, having bariatric surgery than not. So while we don't consider bariatric surgery, again, for the therapy of MASLD or NAFLD alone, it should be considered in patients who meet criteria otherwise for metabolic weight loss surgery. It's been shown to effectively reduce MASLD and MASH, and in the majority of patients without cirrhosis, and it reduces their mortality from liver disease and from cardiovascular disease. Now, there are two therapies that we often think about, vitamin E and pioglitazone, and I won't touch much on these because we're not using them very frequently. They both have side effects that need to be discussed with patients, and the guidance documents, just like guidelines have in the past, say that they should be considered in patients who have histologic evidence of MASH, either without diabetes for those with for vitamin E or with prediabetes or diabetes for pioglitazone. But because we have more promising therapies and these do have side effects, we're using them less and less. So we'll touch on semaglutide for NASH that was published in the New England Journal by Phil Newsom and colleagues. And this was a study that was a 72-week double-blind phase 2 trial of 320 patients with biopsy-proven steatohepatitis and stage F1, F2, or F3 fibrosis. The analysis focuses on the 230 patients with stage 2 or stage 3 out of 4 fibrosis. The primary endpoint was a resolution of steatohepatitis with no worsening of fibrosis, and the secondary endpoint was an improvement, at least one stage of fibrosis. So on the left, you can see here those patients who achieved a resolution of their steatohepatitis with no worsening of fibrosis, and at the semaglutide 0.4 dose, 59% had resolution compared to only 17% in the placebo group, which was significant, as well as even for lower doses. The fibrosis data was less compelling. So 43% of those in the 0.4 milligram group had an improvement of at least one stage of fibrosis, compared to 33% in the placebo group, which wasn't statistically significant. So in this study, we see that NASH or steatohepatitis is improved, but perhaps not fibrosis. And one caveat is this is a very high placebo response rate. We generally don't see a third of patients improving their fibrosis clinically, but nonetheless, this is a randomized trial and it did not show benefit here. But we do think about semaglutide for patients with NASH or MASH to improve their steatohepatitis and hopefully decrease drivers of fibrosis. In addition, both tirzepatide and semaglutide, as you know, are both approved for the treatment of diabetes and are overweight and results in significant weight loss, improvement in glucose metabolism, and decreased cardiovascular event risks. As I mentioned, semaglutide results in MASH resolution compared to placebo, and tirzepatide has been shown to improve steatosis by MRI. So in patients who have other indications for GLP-1 receptor agonists, we do think about using one of these two medications, which will also aid in the treatment of their MASH. And what about resmetirom or Resdifra, which you may have heard about? It's the first FDA-approved therapy for the treatment of metabolic dysfunction-associated steatotic liver disease. So very exciting, and this was just approved in the spring of this year. This is an oral liver-directed thyroid hormone receptor beta selective agonist. So it doesn't have the alpha agonism and the cardiovascular events that result. It's based on the fact that impaired THR beta function is seen in MASH with decreased mitochondrial function and decreased beta oxidation of fatty acids. And so resmetirom was studied in a number of trials, but the most important I'll highlight is the Maestro trial, where patients underwent biopsies at 0 and 52 months and are still being assessed now for clinical outcomes as far out as 54 months planned. These were patients who were 18 or older with 3 out of 5 metabolic risk factors, elevated fat on FibroScan, and elevated liver stiffness measurement or a biopsy showing MASH and fibrosis, and they needed to have a NAFLD activity score of at least 4, with 50% of the study being stage 3 out of 4 fibrosis. So in this phase 3 double-blind placebo-controlled trial, 2 doses of resmetirom were compared to placebo in patients with fibrosis stage 1B or 3. Those who didn't have fibrosis and those with cirrhosis were not included in the analysis of this trial. And the endpoints were similar to those that we saw with semaglutide: resolution of their, what we now call MASH, or improvement of at least one stage of fibrosis without worsening. This trial is ongoing, as I mentioned. The results that were published were the 52-week results, but patients are being followed for up to 5 years. What they found is that those patients who were on resmetirom had significantly more NASH resolution without worsening of fibrosis at both the 100 milligram dose and the 80 milligram dose compared to placebo. And they also had a significant improvement in fibrosis. So up to nearly 26% of patients had an improvement of at least one stage of fibrosis compared to 14% in the placebo group. The differences, they also saw metabolic benefits with a decreased LDL in both the 100 and the 800 milligram resmetirom dose, which is different than, say, when we were talking about obeticholic acid, which had an increase in LDL and subsequently was not approved by the FDA. Diarrhea and nausea are more common in the resmetirom group. But based on these changes, the resolution of NASH and the fibrosis improvement with positive metabolic effects, the FDA did approve this for MASH fibrosis, stage 2 to 3 only. The FDA did not mention that they needed a biopsy. So presumably some insurance will cover this, and we're finding a real variety based on non-invasive testing like ELF, MRE, or FibroScan. Some insurance is requiring a biopsy. And unfortunately, right now, we don't have guidelines about which insurer or which plan is doing which, except that we know the Veterans Administration across the board is requiring a biopsy. So in summary, fibrosis-4 score plus or minus a FibroScan or vibration-controlled transient elastography should be used for the initial assessment of patients with MASLD to determine their degree of fibrosis. For those with indeterminate results or unclear diagnosis, that's when an MR elastography or liver biopsy can be considered. The foundations of treatment include weight loss using a hypocaloric Mediterranean diet, aerobic exercise or resistance training, weight loss pharmacotherapy, including GLP-1s and bariatric surgery. And then MASLD-specific therapies have been looked at. Vitamin E in the absence of diabetes may be helpful. Pioglitazone in those with prediabetes or diabetes. But really focusing on the GLP-1s or GLP-GIPs for the treatment of MASH in those with overweight or obesity. And then resmetirom for the treatment of MASH and fibrosis stage 2 to 3. Hopefully in coming years, we'll have clearer guidelines. Right now, what we're doing is applying for resmetirom for appropriate patients and learning from that experience. Thank you for your time.